We have another young dynamic colleague, Suresh, who is a trained interventional neuroradiologist in Apollo. And we requested him to cover and show some of the procedures where we found this therapy to be useful, and various thrombectomy type of catheters and other things where it is useful. He'll cover up this aspect because first speaker already told us about selection, and then lytic therapy. He will cover up the interventional aspects of the stroke. Over to you, Suresh.
You don't have a mat. You have a mat.
How many of you sitting here who have exposure to primary PC? I think obviously you have because fellows there. How many of centers have stroke intervention programs also? Can you raise your hands? 1, 2, 3. So a lot of work needs to be done. Huh? All of you go back to centers and encourage your neurology colleagues, radiologists to work on this. Actually, at least if you're not going to interventions, the lytic therapy can be immediately adopted, is it not? The patient coming on time is again very important. But if he comes on time, you save a lot of problems. Patients with hemiplegia are densely falling down. So pathetic story. I feel all of us should take initiative in this to save patients. Okay.
Coming up. Okay. This was the marker, and this is for this one. Okay, I can do it from here. Okay. Good afternoon, everyone. At the outset, I want to thank Srinivas Kumar sir for giving this opportunity. So it's more of a technical talk. Again, this not technical talk, and so I'll try to discuss few things about the hardware and how we go about and how the outcomes are, and few real life examples. And Dr. Rajesh, the previous speaker, nicely covered all the indications and case selection and few of the case examples also. There are some connection issues. Oh, do that. It's not coming. Oh, can you give the other one? The videos. I think it is done. Where is it? This one. Okay. Okay. Keep it aside. That. So all the strokes what we encounter at the ER in our hospital or in your setup, they are not all amenable for the stroke intervention. That's the first point we should know. If you do a scan, simple angiography, MR angio or CT angio, if the vessel occlusion is not visible, still stroke will be there. So that is called a small vessel stroke. So the other one is the second image on the right side. You can see that vessel occlusion is there on the right side, some asymmetry you can see. And sorry. So that is called as large vessel occlusion, wherein the vessel occlusion is there on the right side and infarct in the form of that white thing. So this is called as large vessel occlusion. And that's what wherein the intervention role is there. So what is the incidence? This is 2 out of 10. If you get 10 stroke codes in your ER, you get probably 2 cases which are amenable for intervention. Rest of the 8 are not amenable for intervention. They're all small vessel occlusions. So, and visible occlusion, visible arterial occlusion won't be there. So the incidence is only 20%. So in these cases, we need to filter out which is suitable for the intervention, and we try to change the anatomy and clear up the vessel. So thrombolysis has average around 20 to 30% of recanalization, whereas intervention has got the recanalization rate of around 80 to 90%. The recanalization rate of 80 to 90%. So that is why, irrespective of the site of the occlusion, you got these results. So this is what I want to stress upon, that only large vessel occlusions are amenable for intervention. So what are the large vessels? Large vessels are the internal cerebral artery, that is which is marked in the pink. You can see there. That is in the anticirculation, and this middle cerebral artery also up to M2. The reason is what are the devices we have got currently? They can go up to 2 mm vessel. So 2 mm vessels are up to this point, distally up to M2, we can call it as. Those vessels we can chase up to 2 mm vessels, the diameter wise. So we can do it in into anticirculation in the ICA. The left image you can see. So this is the internal carotid artery, middle cerebral artery, M1 and M2. And in the post circulation, we can go up to basal at top and probably into the proximal PCS. So these are the target sites that we can chase. And guidelines, Dr. Rajesh already described very nicely in the previous talk. So guidelines, what they say is basically the window period is up to 24 hours. So that is a concluding thing. And the patients who are having small infarcts or moderate infarcts, these are the S candidates, and this is a no candidate. If you have a large infarct, you don't take that patient. And if you have an IC occlusion, MC occlusion, basilar artery occlusion, you can simply take that patient. And window period is up to 24 hours. The same criteria people are extending up to beyond 24 hours also, but we need to be careful because it's not in the guidelines currently. So few case examples. So the white one is the infarct, and you can see the corresponding arterial occlusion. Symmetry is not there, you can see that. So this is the middle cerebral artery. This was the before image, and this is the after image. This is the device that we have placed. This is called as the Solumbra technique. And clinicals wise, the patient was a 26-year-old female, and she is in second trimester. And thrombolysis was not indicated because of the pregnancy. And patient came with right hemiplegia and aphasia. So you can see that patient is immediately lifting up her right hand and right leg and telling her name. And she was discharged on day 3. So any kind of recanalization, whether you see it in the heart or in the brain, once you recanalize the vessel properly with a viable tissue, with a penumbral tissue, salvageable tissue is there, you see this kind of outcomes. So similarly, one more case. This time it is in the right side. This is the before image and this after image. You can see this entire territory which is showing kind of paucity. Now it is opened up. So this is the device that is placed inside. This is the clot. The clots usually they are they vary between 1 centimeter to 3 centimeters in length. So again, this patient was having this on-table improvement. You can see that he came with left side hemiplegia and an examination. I think this issue with the video. So he's lifting up his left hand and left leg immediately after the procedure. So this you see this is on day 2. So how do we achieve this kind of outcomes? Not only technical, but the case selection, all those things will come into picture when the outcome comes into the matter. So the first device which came historically, which was invented or which was used to be for recanalization, was it used as an accidental or inadvertently it was used for the intervention. Basically, this is a a kind of nitinol cut. It's a kind of a sheet of a nitinol cut mesh, which was folded in like a tube. So this is called as solitary device, and you can see the clots on that. So it is actually used for the stent tested coiling. Accidentally, in one case, the coil purposes it was used for retrieving the foreign body. Similarly, it was used for the clot retrieval also in 2009. And then onwards, further improvements were done on that particular device called as stent retriever or solitary device. So how we do? So sorry, this is actually. So how we do? First of all, we cross the clot with the mic catheter, and then whatever the stent I told, it is basically mic catheter deployable stent. So then we deploy the mic catheter, and after that we deploy the stent retriever. The stent retriever, once it is there, we keep it for some inhaling time, maybe 5 to 10 minutes. Ideally is 5 minutes. And after that, along with the clot and the stent retriever, both of them are pulled out. So stent retriever is a kind of stent with a attached wire to it. It can't be detached. Even if too much of force also, usually it is not detached. So very accidentally, if you reuse it for maybe many times, probably it may detach, but usually it won't detach from its parent stent strut. Some of the stent struts are made up of single wire along with the struts also. So in those cases, it is unusual to get detached. And after that, then you pull back and remove the entire clot structure. So to get the clot out. So this is the mechanism. So how to access the clot? The clot access is composed of triaxial system. So because one of the target sites are very distal and tortuous in nature, we use kind of triaxial system which composed of a long sheath, an intermediate catheter, and a mic catheter. So these three systems are available. The outer sheaths are kind of 8 French guidings, or 6 French long sheaths. The inner one are 6 French guiding catheters, which can go up to middle cerebral artery. They are so malleable and can go up to middle cerebral artery. The innermost one is a mic catheter through which a stent retriever is deployed. So these are the specifications of the intermediate catheter, the green one. And coming to stent retriever, different designs are available. Out of which the left one, which is a parametric device, which kind of a folded sheet of the mesh with a radial force within it. So solitary is the one. So all these the third generation, the stent retriever is more of a kind of segmental type to get the clot properly as compared to the second generation ones. So what we are getting in the form of the solitaire as well as the striatal retriever, these are second generation devices. So these are the specifications. They all come in the range of 4 to 6 mm. There are some baby stent retrievers also available, which are in the sizes of 2 to 3 mm. And these are the mic catheters. They're all 0 to 1 diameter, and the length up to 160 centimeters in diameter. So these are on fluoroscopy, it looks like this. So this is the stent retriever in the brain, in the middle cerebral artery in the right side. This is in the AP projection, this is in the lateral projection. So this is a kind of third gen, the further modifiers of solitary device. You can see that this radiopaque markers, which are kind of impregnated within the body of the solitary also. You can see up to here. So you see that whether it is properly deployed, it is properly expanded or not, you will come to know with the help of this particular the radiopaque markers. And what you are seeing as a tube here with a radiopaque ring kind of thing, this is the intermediate catheter. The size, the outer diameter is around 6 French, and we use basically both of them together, which is called as Solumbra technique. The technique requirements and all I'll let you know in the later slides. So this is a case example. It looks as if the MCA is patent here, entire MCA, but it is not. The inferior division is missing. So this entire area is missing here. Paucity is there, as you can see here. So this particular branch, which is supposed to be here, it is not seen. So this was crossed. You can see the mic catheter. And once you cross, we'll take a distal injection to see whether we are in the proper vessel or not, which is in the target vessel. So the same way in the lateral injection, you can see this is the entire paucity of the cortical vessels. So this particular vessel was crossed, and we did a mic catheter injection. So you can see the AP and lateral positions of the corresponding crossing and taking of the injections. After that, then we start deploying the stent retriever. You can see that the constrained stent retriever in the mic catheter. So while deploying, you should know where we want to deploy it, probably site of the clot. So in this case, the site of the clot was here. So I would deploy the stent retriever probably 1/3 distally and 1/3 across the clot and 1/3 proximally. So that is what the plan was. So you can see that how it's getting deployed. So this is self-expandable stent retriever, and the microcatheter was deployed, and the got kind of withdrawn, and it's kind of getting expanded across the clot. And in the lateral image also, you can see that. So the distal target position, I don't want that distally. So I kind of pulled it out and try to expand it and deploy it across the clot. So once it is across it, then you can engage the intermediate catheter also into the mouth of the clot. So this is about deployment. And after that, you can see the recanalization after the pulling back of the entire system, retrieval of the entire system. You can see that this opening up of a new vessel, which is corresponding to a big territory, and it's on the left side. Patient came with complete hemiplegia and improved in 2 days' time. So a young guy in his late 30s. And this is the corresponding image of the same patient. You can see that vessel, open vessel. This entire territory is now open, which is showing paucity here. And another case, you can see that this is a basilar occlusion. So how a stent retriever is deployed, you can see that here is a probable clot, and it is the clot extent is from here to here, but the stent retriever we deployed quite significantly distally, so that the capturing extent of the clot will be significantly better as compared to just deploying it across the clot. So you can see after the deployment and after the retrieval, you can see the opening up of this particular basilar segment with some amount of atherosclerosis, intrinsic or atherosclerosis present. So these are the different territories and different sizing of the stent retrievers. So you need to use a proper size stent retriever. Otherwise, if you oversize it, it may share the vessel. If you undersize it, it may not capture the clot. So this is very important according to the size where you are chasing. Some patient may have a bigger vessel. Probably we need to adapt accordingly. Where the clot is there, the clot will come to know on the imaging. Accordingly, you can plan the intervention. So for a ICA terminus, which is a bigger vessel around 4.5 mm, so we used a 640 stent retriever. As you can see, this is a stent retriever. This is before and this is after. You can see the site of occlusion is completely opacified here, recanalized here. Whereas, sorry. So this is very distal location. You can see it's in the antecerebral artery. So there, the vessels are smaller in caliber. You can see it's around 1.5 mm. So we use a stent retriever. This is stent retriever mesh kind of thing. We used a diameter of 3 with a length of 32 mm. So we need to size it according to the vessel, target vessel. So how to get the best outcomes? Best outcomes is basically 50-50%. 50 clinical criteria. If you properly seeing the imaging, properly evaluating all the clinical factors, that gives that is very important. Proper case selection. Apart from that, technically, you need to have 3 things in consideration. First is that you need to open the vessel entirely in its entirety, more than 50%, or you can say 100%. If you go open, the outcome is the clinical outcome is going to be good. The second thing is you have to open the vessel at the first go. It is not a rule, but if you get it in the first go, the outcome is going to be better, because the more the number of passes you are going and chasing, the time is going to elapse more. That's the first reason. Second thing, the number of passes you are taking, the clot is going to change the morphology, and the chance of getting it retrieved in the second or third passes will become more and more lesser. And the third thing is faster. If you get a first pass recanalization, obviously it is a faster recanalization. So always aim for the first pass recanalization and achieve at least 2C recanalization or TK3 recanalization. Means more than 50% of the territory you have to recanalize. So what are the techniques? Apart from the stent retriever technique, we have got the aspiration thrombectomy or a combined thrombectomy, called as the stent retriever or the solitaire plus penumbra, called as Solumbra technique. Why it is important? Some clots are very much amenable for retrieval from the stent retriever, like soft clots, longer clots, whereas very fibrin-rich clots are very resistant to stent retriever. So these are very good for the aspiration thrombectomy. So if you combine both of them instead of using singly, solely, so definitely you'll get a better outcome. So these are the factors, physical factors of the clots and their interaction with the stent retriever or the aspiration catheter. So few of the clot characteristics are in favor of the stent retriever, few of the clot characteristics are in the favor of the aspiration catheter. So it's better we use combinedly. So this is called as Solumbra technique or SAVE or BADAS. So many names are given. Where in the mouth of the clot, the aspiration catheter is present and the stent lever is simultaneously deployed in a sequential fashion. So then you retrieve this assembly of stent lever as well as aspiration or the intermediate catheter in toto after some inhaling time. So this is called as Solumbra technique. So you can see that this is the Solumbra, this is the intermediate catheter in the fluoroscopy and this the stent lever. You can see the before and after. So the why we are using combination of devices to get the first pass effect and to get the best outcome. So that this aspiration catheter also will be helpful to avoid any distal embolization of fragments of clots while you are pulling it out. So we want to get the best outcome at the first go. So then we will get the best clinical outcomes also. So another case, so you can see the level of occlusion. You can see the stent lever and the aspiration catheter. The aspiration catheter sitting into the mouth of the clot, and you will get this kind of technical outcomes. Case examples again, posterior circulation strokes known to be very having the worst outcomes. Already brainstem significantly involved. You can see the before and after images. And at the time of presentation, he was intubated. The GCS was 5, and this is after 2 months. He was weaned off and did tracheostomy, and after tracheostomy, you can see that he is walking. Still some spasticity is there, but he is able to do his activities currently. Another case, complete right ICA occlusion, but cross flow is there. ICA is missing, but he was having recurrent TIA. We recanalized without any distal emboli. So here the problem is, while we are venturing into recanalization, you should not cause any distal embolization, pushing of the clot into the normal circulation distally. So you have to be very careful with your technique. And these are the clots that are taken out and use the patient. And this is a post-CABG patient. So ours is a very high volume cardiac center. So this is done recently last month. Post-CABG on day 2, we can see that the patient had dense hemiplegia and immediately called, and we did the CT perfusion. And you can see the complete revascularization, and this is on day 2. Patient was walking. Another case at 4.5 hours, you can see the on-table improvement, left MC occlusion, elderly lady. You can see that the vessel is completely recanalized after the thrombectomy. So this is my experience around 340 cases, which were analyzed 2 months back, out of which the window period was this I want to stress upon is that most of the patients which come to us are more than 6 hours window period. They are not up to less than 6 hours. Only 1/4, I can say, they come in the less than 6 hours window period. Most of them are more than 6 hours. They come from periphery, and even if they come also, the decision taking time will be there, because of which the onset to puncture time will be more than 6 hours in most of the cases. But the outcomes are comparable. Outcomes are not lesser in patients who are more than 6 hours. So it is not the time window, but it is the tissue window that is more important. So if you are selecting the same set of patients with the same core of infarct, in whether you're taking less than 6 hours or more than 6 hours, the outcomes at the end of 3 months, although the patients who are coming at the less than 6 hours, the recovery will be faster, but the patients who are, if you are taking comparably same infarct core, the outcomes are comparable in the range of around 70%. So, but this is not as rosy as we had discussed. There are some practical issues and complications we should know of. Difficult target access will be there. Sometimes you may end up doing incomplete recanalization. And if you've done a very good technical angiographic outcome, but it may be futile if you are choosing a wrong patient. This is called as futile recanalization. And in India, in our setup, it's still awareness and acceptance an issue. Affordability is the most significant issue. Complication we should know of while retrieving the clot, the stent lever, it may cause subarachnoid hemorrhage, can be benign most of the times. If it is perforation kind of thing is there, it may be sometimes may require decompression, and it may affect the overall clinical outcome. And embolization distal territory, which is the most feared complication while venturing thrombectomy, and dissection of the access vessel, vasospasm, and intracerebral hemorrhage due to perforation of the vessel. So these are all the complications. And to conclude that, we should understand that recanalization rate is up to 90-95% is now described. but it won't transfer into clinical outcomes. Maybe 20% difference will be there if you are selecting properly those patients. So 90% good outcome, good technical outcome, maybe transfer to 70% clinical outcome. And first pass effect up to 50% of cases is possible now. The better the first pass effect we get, the chance of clinical outcome will be better if you are choosing a correct patient. And once we are doing venturing into it, so we should know about the device compatibility. What is the kind of physics of the clot, whether it's fibrin rich or thrombin rich, by seeing the image and vascular anatomy and decision making and planning, all of them will come into picture. So technical outcome wise, you should always try to achieve 2C by 3 recolonization and faster and first pass effect for best outcome, best clinical outcomes. Clinical outcomes are the ones which we actually aim for rather than angiographic outcomes. So if you want to get it, probably you need to get these recolonization parameters. Thank you.
Thank you, Suresh, for covering it up well, and congratulations for good work which you're doing. You should be source of inspiration to a lot of youngsters here. And one thing, many of the times when you take up the procedure, one thing which you made it different was if a patient has a large stroke, like large MI, you're doing primary PCI, there's more benefit for us. But you mentioned that if the patient has a large stroke, it doesn't benefit. Huh?
That if you're doing less than 4 hours, probably some benefit may be there. And some benefit, I have a series of data of large cohorts, around 45 patients. In that, 30 patients improved at the end of three months. So sorry, 30% of patients means 12 patients only. So the problem is in India, if you say that out of 10 patients, 3 will improve, rest of the 7 will be bedbound. So most of them won't accept it as a procedure. So that is the
they come very early also, they won't improve.
Sorry, sir?
If they come very early, within 1 hour also, they won't improve.
Most of the times, a large course, they won't improve.
Anyway, thank you. I think all of you should take more interest, and there's more need requirement. Nowadays, people are smart enough to decide the process of earnings and things like that also. Those people will be rewarded much more than cardiologists also. That also keep in mind. So not only for that, but there is requirement, clinical necessity for patients. I think, thank you, Suresh.